My name is Mary Conquest. I'm your host for Safety Labs, the podcast where we explore the human side of safety to support safety professionals. We move past regulations and reportables to talk about the core skills of safety leadership: empathy, influence, trust, rapport. In other words, the soft skills that help you do the hard stuff. This podcast is created by Safety Products Global, the world's leading manufacturer of safety knives. Through our trusted brands, Clever, Slice, and PHC, we empower companies to prevent injuries by providing safer cutting tools for every material and application. Hi there. Welcome to Safety Labs. When I think about hospitals and safety, especially pediatric hospitals, I tend to think of patient safety first, and I think that's common. Maybe it's because pediatric hospitals treat some of our most precious and vulnerable family members, or maybe we buy into the cultural belief that pediatric healthcare workers are invincible superheroes. Today's guest has a unique perspective on patient safety, worker safety, and the status of OHS concerns in the medical field more generally. Dr. Anne Lyren is the Chief Medical and Strategy Officer for the Children's Hospital's Solutions for Patient Safety, or SPS Network. The SPS Network is a pediatric healthcare safety collective of over 150 hospitals across North America. Dr. Lyren spearheads strategic efforts to eliminate healthcare-associated harm for both patients and staff. She's held executive roles at UH Rainbow Babies and Children's Hospital, including Vice Chair of Quality and Safety and Interim Co-Chair of the Department of Pediatrics. Anne holds degrees from Harvard University, the University of Edinburgh, and Case Western Reserve University. She brings a unique blend of clinical medicine and ethics to her work as a leading international expert in pediatric healthcare, safety, practices, and culture. And Anne joins us from Cleveland, Ohio. Welcome.
Thank you, Mary.
So I want to get straight into what I mentioned in the intro, which is the relationship between patient safety and healthcare worker safety. Most people see them as quite separate, but you argue that they interact in a few different ways.
Definitely. So it's been an interesting journey in Solutions for Patient Safety, or SPS. And I would say that our perspective on this issue has changed over time. When we first started, as you can tell from our name, the Solutions for Patient Safety, we were inspired by the need to keep children safe who came to our hospitals for care. And we're very aware of the ways in which we did not succeed in doing that. And so that was really the motivation for the organization of these children's hospitals in the beginning. And it really felt fairly magical at the beginning, to be honest, because of the power of that mission. So no one really wants to hurt a little kid, period. And you especially don't want to hurt a little kid who's come to you to be healed or to get care. Nobody goes into healthcare to harm anyone. And in particular, people who choose to go into pediatric healthcare have a certain kind of fondness and advocacy for children that really, really motivates what they do. So we started our network and we were kind of chugging along, working on patient safety. And in the background, we became aware of information that wasn't hidden to us, but what we hadn't really paid attention to, which was the relatively severe statistics related to hospital safety. And this, of course, wasn't unique to children's hospitals, but OSHA, for example, in the US, repeatedly states that hospitals are the least safe place to be. And safety in hospitals is worse than the construction industry and oil and gas. And so you sort of hear these things as coming from it being inside, but it's a little bit hard to process them. However, we began to appreciate that these numbers were, in fact, representative of real people when we stopped to think about it. And they were manifest in ways that were interesting actually in hospitals, fatalities of employees are rare. So it's not maybe like on an oil rig or in a coal mine or something like that. But then there's a tremendous amount burden of non-fatal injuries that are quite debilitating. And then there's also the issue that has become more magnified in recent years around violence exposure in hospitals. So maybe about 6 or 7 years into the history of our network, we started to appreciate that we wanted to go there, that we wanted to think about safety in children's hospitals holistically. We wanted everyone to be safe. And some of that was motivated by these sort of numbers that we heard. Some of it was theory, like, Maslow's hierarchy of needs. Like, it doesn't really make sense. How can you keep someone safe if you're not feeling safe? That kind of thing. And some of it was early on, there were a couple of hospitals that were actually looking at their data and were willing to kind of share and say, I'm not really liking what I see in terms of the number of injuries. So we thought, well, at this point, we had been already realized some success on the patient safety side working together. So we thought this is going to be a relatively easy slam dunk. We'll jump in with employee safety too, and we'll bring the same model that we did to employee safety or patient safety to employee safety. And so we got started and we picked a few things to work on, which we felt were the most common ways that employees were harmed in children's hospitals. And they were overexertions. So, push-pull injuries and things like that. Patient behavioral events. And those are a form of workplace violence where patients actually injure employees. And the last one that we chose to work on was slips, trips, and falls. So we put together teams and we got started on this. And the short story is about 5 years later, we'd made no improvement, nothing, which was mysterious because in all the other 10 patient safety areas that we had tried, we had really pretty quickly had, notable success. So what was happening here? Why was this not working? And and this is still part of what we're trying to figure out, but a couple of interesting parts about it. And it kind of depends on which one of those things you're talking about, whether it's the patient behavioral events or slips, trips, and falls or overexertions. But employee staff safety in general was not as easy a lift because for reasons that feel uncomfortable even coming out of my mouth, the mission was not as compelling. People were not as motivated to keep themselves safe and their colleagues safe as they were to keep their patients safe. And there were, a couple of things that contributed to that. I think one was that sort of advocacy role that pediatric providers have. And it's very, very strong. Children are vulnerable, more vulnerable than adults, obviously. And so, and that kind of need to focus on them was so strong. And we were able to capitalize on that when we tried to improve safety. But that same feeling did not exist when it came to employee safety. So, again, I'm happy to talk more about the details. Like, I think workplace violence is a really interesting one too. But overall, that dynamic and the mission was a little bit different. One other thing I would say that we realized is that there's actually a tension between patient safety and employee safety that is fascinating. So, and I'll use as an example these patient behavioral events that I referred to. So, children sometimes injure their care providers who are rushing to rescue them. And the people rush to rescue them maybe without the appropriate ergonomics or the appropriate equipment. And they rush to rescue them in situations that have been normalized. I'll tell you an example. When we first started this work, we put together a team of people, and there was a physician leader who was a psychiatrist by training and had been taking care of children with autism. And when we were talking about injuries, she pulled up her sleeve and she was showing me all of these bite marks that she had. And they were, and healed, but they were scars from being bitten. And what was the most interesting part about it to me was this sort of perverse way that it was like she was a martyr, and that these were examples of how she had been so devoted to the patients. And I think, most people would agree that's not, something's off. But, and maybe that's an extreme example, but I think that it sort of exemplifies a theme that runs underground, kind of undercurrent is a better way to say it, that children will commit sins that we are going to forgive, and that we're expected to deal with people who are very, very stressed or very ill, or developmentally not capable of understanding what's happening, and that we are advocates, we are self-sacrificing, and we have a duty to rescue them. And all those things kind of come forward to lead to the bites all over your arm kind of thing. So it's a very interesting tension between the duty to keep a child safe and the duty to protect oneself and one's colleagues.
Yeah, I was thinking the way you explain it just now, it's part of your identity almost, right? It's part of your vocational identity to be, well, I don't know that they teach sacrifice, for example,
yeah, right,
but I can see that it's part of the personality type and mindset that would go into that kind of field. At the same time, that's a tension, but I would imagine as well that better patient safety to some degree leads to better worker safety in terms of maybe psychological harm or maybe even behavioral events. I'm not sure. What do you think?
Yeah, I think you're right. Well, there's a couple ways that better patient safety begets better employee safety. One is maybe a little more oblique, but still, I think, very powerful. And that is that in the hospital, as you change the culture about how we think about human beings being safe, it does sort of trickle into other areas of operations, if you will. And I think that we even saw that a little bit before we started our explicit work on, more occupational safety and employee safety in our work, is that there were some kind of enterprising teams and hospitals that were borrowing some of the methodology and tools and things like that were being used in patient safety. And I think that it's very interesting because this was not at all a hard sell for executive leaders. They were very, very interested in keeping their employees safe. And they were very genuinely wanting to improve employee safety. And so it was super interesting because when we weren't succeeding in improving employee safety, we thought, well, like, what is happening? And of course, we all wanted to, it's a leadership issue. There must be a leadership thing. And I interviewed, members of our participants in our work, interviewed people from kind of the front line to leadership to try to understand what was happening, and what was it, a will issue? Was it where is the problem? And it was very interesting because the top leaders were talking the talk, and it was not disingenuous at all. It was very genuine. And the front line would say, our leaders our president, our CEO, our board, they care about us. They care about our safety. They heard them. It was this entire mess in the middle that made it not work. A lack of alignment. Like, it's one thing to talk, but like, how is that structured? What does that look like? How does that actually, that desire to keep the front line safe, where are their goal conflicts? Where are their sacrifices? Where are their investments? Where is their organized leadership? What are they talking about at executive meetings? So it's sort of in there that the problem was. And so, kind of back to your question, patient safety, improving patient safety and improving kind of how the organization is sort of vertically aligned to improve patient safety is also relevant to employee safety. And so how does that happen? And I think there's been some gains there. I think also having people, if you're a frontline provider and you see all this emphasis on patient safety, you kind of got safety on the brain. And you do begin to think about safety of yourself, of other people. And I'll give you an example of where that can be really awkward. So there are, unfortunately, not rare examples of children, by definition, they're under 18. They might be in adult-sized bodies. They get admitted to a children's hospital because children's hospitals are frequently safety nets for children. And they have behavioral health problems, and they have nowhere to go when they don't have a family that can care for them. There's not a plate. They don't need to be institutionalized in, a psychiatric hospital, or maybe they do, but there isn't one available. And so there's a big, like, mega problem of managing behavioral health. And so now you have this child who's in this setting and who can be violent, and is big enough to really hurt somebody, has hurt people. And now you don't have anywhere you might be able to get them to the point where they're ready to go home, but you have nowhere to send them. And so now they're in an inappropriate environment and they're stuck there. And when I say stuck, like months in some cases. And so they do what they cope as best they can, but not there. Again, examples are not unusual of repeatedly being violent. And you can kind of understand it. They're in the wrong setting. And so if you work on that unit, you begin to ask yourself, like, okay, what's happening here? Because Joe was hurt 3 days ago and Jennifer was hurt yesterday, and now I'm assigned to this patient. Like, and I hear my CEO talking about my safety, but I'm a little and so but yet again, we're trying to keep the patient safe. And so I think that it does sort of highlight these examples of that, the tension between the two. But even that tension in some ways, when I have my rose colored glasses on, can be good because it does sort of elevate the conversation about employee safety in the midst of trying to keep patients safe. So I think that might be another way that the two are kind of intertwined in an interesting way.
So one challenge that a lot of my guests or people in the safety in the OHS profession struggle with is organizational change. I mean, who doesn't? I think that when you were listing the undercurrent, you called it, of beliefs and ideas and all of that, to me, I hear the word culture in my head, right? It's culture, which makes it a little bit slippery, harder to pin down than a procedure or a checklist. So there's a goal to shift that mindset. And you did say that you had some gains at some point. How did you begin to shift that mindset? Or is that that's what you identified? Is that where you focused when it came to worker safety?
Yeah, so we have really evolved. So I think when we when we first started, we were very focused on, and both for patient and employee safety, we were very focused on sort of safety ones, like standardization was king. And in patient safety, there was a ton of low-hanging fruit there. Like it was really like relatively arbitrary how people did safety critical processes, and so there was some good evidence to say this seems like, generally speaking, a better way to do things, and so we kind of latched onto that and tried to get everybody to do it that way. And there's a when you're in chaos, if you want to call it that, there's things to be gained to get to standardization and have some sense of like best practice. And the same the kind of a similar thing happened with employee safety, where we were like, why would we recreate the wheel? This is how you pick up a patient. This is how you pick up a box, kind of thing. And so we worked really hard to standardize, but in both cases, both patient safety and employee safety, we appreciated that that model was problematic. And there were a couple reasons why it was problematic. One was that it's disrespectful to work as done. And I think that there was so much focus on adherence to standards that there was a lack of appreciation for what is included, for why people adapt, and how adaptation is a success strategy in a very complex system like a hospital. And that adaptation is really sort of the kind of golden nugget to learn from about why it is that people do it the way they do it. And I think it may have been when we were in chaos, the people that did the way they did it because they figured out that that was the way that made it work. They could kind of make it work, but there were better ways to do it, ways that were more efficient, ways that were safer, etc. But so once we got to a reasonable standard, then adaptation from there was very meaningful and very much gave us an opportunity to learn. And so in both employee safety and patient safety, we began to kind of shift our focus from a obsession with standardization to creating a mindset that is really more about learning about the system and learning about adaptation. And a couple other things that I would tell you is that in our world, culture, culture is sort of like, what is, you and I can both spew off our favorite definition of culture, but it's very complicated. And of course, it means different things to different people. How an organization defines a culture might be a metric from a survey, or might be some. So I find it sometimes very difficult to talk about culture, but for our purposes, the culture is really the attitudes that people have, the values they ascribe to, the ways they think about the ways they think about interactions and their work, and the way they behave, with each other as part of their teams, etc. And so when we first started our network, we appreciated, I think correctly, these many years later, that process improvement alone wasn't going to do it. Even if we could, we would fail in standardization. So we decided that we were going to explicitly address culture. And culture was kind of how the way we talked to each other, the words that we used, the way leaders reinforced those kinds of things, how we handled events when they happen, how we thought about that, how we so those were kind of the big, how we handled disclosure to families, how we engaged families. those types of things. And another big part of that was leadership. And one of the things that we did that continues to pay tremendous dividends is we started a board training program. And so we have now trained, I don't know, close to 3,000 Children's Hospital board members in safety in children's hospitals. And so these are people who are, bankers and have all kinds of backgrounds and volunteer to be on children's hospital boards for the mission, right? The mission. And in it 25, 30 years ago, I would argue that probably most of them, they had no clue that people in children's hospitals were being harmed, neither patients nor employees. And so part of what we did early on was kind of link arms and decide that we're going to start talking about this with our board members. There, as usual, were some front running hospitals that were already beginning to do this. And they provided great inspiration for others to, like, the world isn't going to implode. These are people. You can explain it to them. They might be disappointed to know that these kinds of things happen in their hospital, but then they're going to get behind you. And so teaching board members how to lead for safety has been an important part of our work. And doing that, I think, helps with those leadership transitions that you referenced, so that it's not just a CEO, that there's a board, there are lots of people who are kind of involved in this culture that's considering safety and not just a leader. And so that's been a really important thing. But just kind of back to the evolution. So probably about maybe four-ish years ago is when we really decided we're going to move beyond standardization and just trying to improve reliability to practices. And that is required. It's like, I remember, Mary, the first time that I presented the new concepts to our board, the SPS board. And the first comment that someone made back to me was, that doesn't feel like a very big change. And I thought, oh no, I have failed, because it's a massive change to move from, sort of a safety one mindset to much more of a safety two, kind of bringing in concepts like resilience engineering and human factors engineering and, human and organizational performance and organizational psychology and like things like that into the work, instead of just old school standardization, process improvement, reliability to the processes, audit and compliance. That's how we're going to spend our resources and spend our time. And then, they eventually kind of got it, but it's hard to see what a gigantic shift it is. Where we are now is entrenched in that and really beginning to see some of the fruits of our labor on both the employee safety side and the patient safety side. So on the patient safety side, just to give you some reference, we did have, as I referenced earlier, pretty dramatic improvements in almost everything we chose. I think everything we picked to work on. And then it started with the asymptote, right? So we got a nice bit of juice out of the squeeze from standardization and audit and compliance and reliability. And then we got the asymptote. And when what you're talking about under that line is a child being harmed, that's not okay. It's still very, very motivating to try to improve that. And so we have begun to shift the actual work that we're doing away from audit and compliance and towards more modern concepts and safety and tools that sort of support those, and are beginning to see additional gains from that. So it's pretty exciting. Do I think it's the last iteration? I don't know. It might be the last iteration for me because I'm getting old. But we're continuing to make progress, and we have a lot of energy because this idea that we're not just, going around with our rulers and whacking people's wrists because they didn't do it the right way, and instead elevating those frontline providers as the source of truth and as from whom we need to learn. I think that really speaks to a lot of people, at least in our industry.
Yeah, it definitely shifts the conversation. I'm excited to get into more of some of the details here, but first we're going to hear from the company behind the podcast and one of their tools. So in warehouse, distribution, and retail environments, cutting tools can take a beating. Flimsy blades won't suffice. So traditional knife designs can also increase the risk of injuries and damaged goods, which is why Clever Cutter built the Clever Eco Exchange XD. The design with the hidden blade, I guess. It protects fingers and it protects merchandise. The blade head is engineered to be 50% stronger and last 4 times longer than similar cutters. There's an integrated tape splitter, which saves the blade for cutting. It cuts up to 1 mile of corrugate, and when it's time, you only have to replace the blade head. You can keep the handle and get a new head. If you'd like to learn more about which tools will work for your materials, you can request free samples by going to safetylabspodcast.com/samples. And now back to our podcast. When you look at your work and the larger context of the medical industry, do you feel like the medical industry is keeping pace in terms of occupational safety with other areas, or?
I don't think we're winning this one. I think that we continue to have a will issue. And there's a lot of reasons for that. One, like I'll give you an example for overexertions, which is a really common one. And these are things like patient handling, or would be a pretty common one. When someone has a terrible back injury, say a nurse, she just kind of disappears, right? She just doesn't come to work the next time. And it's not visible except for her friends, who will miss her. It doesn't have a high degree of visibility in the company. Okay. Like maybe
the signal is quiet.
That's very quiet. She just didn't come to work she just wasn't on the schedule next time. And it's almost like you'd have to think about her as a person in order to miss her. Meanwhile, she is devastated, right? She is suffering from her injury. So that's a handicap in terms of building will. I also mentioned kind of like the goal, the other priorities, the goal conflicts, and the mentality of kind of expecting to be in high risk situations in service to the work, in service to, like for instance, workplace violence. It's an interesting world, right? If you take the healthcare providers out of it, all the people that come to the hospital are having like the worst day of their life, or one of them. They're all under a tremendous amount of stress. They're not at their best, and they're not feeling well. So, the patients themselves are feeling terrible. And so there's so much grace. There's so much grace for this. There's so much normalization of that people get themselves in tricky situations. And I think that we haven't really reconciled that tension in healthcare either. I think the other thing is that in our world, employee safety has not been highlighted in the academic work either, in the way that it needs to be. So, for example, some hospitals in our network work together. They actually just published an article in the Journal of Pediatric Nursing. And what it's about is the impact of these patient behavioral events on other aspects of work and the person. So, and what they found that's not going to surprise you, but is good to codify is the impact that a terrible event like that has not just on the person that experienced it, but secondarily to people who even hear about it. So if I hear about an event, I might be afraid. And so I think that it makes sense to you, right? It makes sense to everyone that could be the case. But this was really unique in the medical literature to have like write this down, like show people, and to actually kind of codify it in technical and academic peer reviewed way. I think the other thing is that the other reason that I feel like we're not moving as fast as we need to is because I continue to hear stories of instances where decisions are made that subjugate employee safety, not intentionally, but because a lot of different priorities are being balanced. And I can give you many examples of where patient safety was prioritized clearly and other things suffered because of it. I can give you many examples of where patient experience was prioritized and other things suffered because of it. I can give you many examples of where finance was prioritized or efficiency was prioritized and other things. I'm hard pressed to find examples where employee safety was prioritized and other things suffered because of it. And I think that, I recently heard a story that was about a situation that happened in a pediatric emergency department where a first year resident went in to see a patient. And well, let me back up by saying the leadership of the emergency department had been advocating with the administration that more security needed to be put in place to detect weapons and things like that. And this is all very expensive. This is a relatively safe community. They haven't had a lot of precedent for this in their community. And so, it's a good thing we're not over there where they have all those bad things, but we're here. And so it was just falling on deaf ears. And the person even produced, some literature like, we have like, look what it says in the emergency medicine societies, et cetera, are recommending this. And it was just kind of like, yeah, but, and a patient came into the emergency room and a first year resident, went in to interview and was sprayed with mace. And then someone, other people rush in to rescue and are getting, urine thrown in their face and, all kinds of things. And then of course it's like, going back to the administration, now there's a story of a person who was injured who may not come back to work ever, because of this experience. Other people who have heard about this and are frightened to come to work because of this. And I think it's these kinds of stories that would make me feel like a fool if I said, "Oh yeah, we're doing great here. We're just keeping right on up with," I don't think so, Mary. I think we still have a lot of work to do. And that does not mean that there aren't some areas some signals of positivity, but I don't think that occupational safety is where it needs to be. It's not where patient safety is. It's behind patient safety in healthcare. And I don't think that it really is even as, when I talk to people from other industries, I know that everyone is in a continual effort to try to improve safety. But I do wonder if healthcare kind of continues to lag behind in that realm as well. It's sort of hard to compare, but I think there's some real opportunity, to use the euphemism there in terms of occupational safety.
Some of the things you're saying are reminding me, it seems like a lot of this, as we said, culture, and you said there's a lot of things that are intuitively understood but not codified, right? And that's the area that you're looking at. That's a little bit harder. One of my previous guests used the phrase making the water visible. In other words, like one fish says to the other, "How's the water?" And the other one says, "What's water?" Right? So we're swimming in these beliefs and ideas, and we're not always aware of them. And even making ourselves aware of them is almost the first step. Talking about adaptation, you've called it both a superpower and a kryptonite in healthcare. And I think you've already mentioned like approaching it as not as a punitive thing. Like, why did you do this in it, with that tone that I just used? Why did you do this? And I imagine there's a lot of adaptation because there are like the situation you just described. Things can happen quickly. It's quite a dynamic environment. Trying to understand something that happened and trying to understand the adaptation that was made or the decisions that were made by the worker at the time. How can you decide whether an adaptation was successful or helpful or the opposite?
Yeah, that's a great question. And that is, I think you have to learn from the person. So if I'm a person who was involved in some, like, we often choose situations that have a bad outcome to learn from. And I think that's okay. But we also need to understand how we do everyday work, because those adaptations are also happening there. And we don't need to have a bad event to learn about that. But the ones that tend to come under the most scrutiny, at least historically, before we really began to kind of learn from normal work and learn from successes too, the other end of the bell curve, was doing our best to make sense of what the context was, what the mindset was, what the available information was that caused that person to make that decision at the time. Actually, Bob Edwards I heard him speak recently, and he said he told a story that I really like. He was talking about a boss of his at some point in his career, and something bad happened. And the boss said, why don't you go learn until I don't want to fire someone? And I kind of like that. It's like, keep understanding what happened, because unless we have this wrong and we've just hired a bunch of criminals here, there's there's a lot of learning that needs to be done to understand why people do the things they want to do. And I think that, again, we have grown up, if you will, in a world that saw adaptation as deviation. We use that word deviation with the same root as devious, right? Like going the wrong direction. And I think that it just you kind of have to get over that and really see that people are doing these amazing things to successfully deliver healthcare all day long, every day. And it has nothing to do with, the policy, or it's everything to do with wanting a successful outcome. And so I think that idea of appreciating that people make the best decision they can with the information they have in the situation they're in. If you're willing to have that mindset walking in, you have so much to learn about what's happening. Interesting thing happened with COVID. So we have this is a patient safety example, but you'll appreciate it, I think. We have these things we call bundles, and they're just a series of processes to try to prevent a certain kind of harm. And there's some that we had that were like mad detailed. I mean, just like first you do this, then you do this, then do this, like, obscenely detailed. But we had evidence. We did that and it worked. So come on, people, like everybody needs to do this. This was, before we kind of like had you know, started our revolution. So then COVID hit. And as you know, the nursing field was really turned upside down. And so there were a lot of traveling nurses, a lot of transition. And so a hospital that would, typically have, I don't know what the right percentage is, I'm making this number up, 85% of their staff is just kind of going along. Like there's not that much turnover. There's not that much in and out. Now it was just chaos. People are going to different parts of the hospital and different units. We're bringing traveling nurses in. We have a shortage. It's crazy. And there was a lot of complaining about that. They don't understand how we do it here. We don't understand how we do it. And what was so fascinating was when the dust started to settle, the examples that started to bubble up of, well, we started to do it a little differently because one of our travel nurses showed us this thing. And it was a different adaptation that actually worked a little better. And I think that experience, again, after kind of the emotion kind of settled out of COVID, and we started to think about like what actually just happened in our industry, that there were some interesting experiences like that weren't rare, where people could see how there wasn't just one way to do it, and that adaptation was really, really, really important. And so I think that the crazy thing about healthcare that I kind of came to later is seeing the superpower of adaptation too. Like, actually, if we do force people to do it a certain way, we actually lose, because it's in that adaptation that we win. So let's all be clear on that is how we deliver safe care. That is how we keep employees safe, because they do things that are not written in the policy, that are not standard operating procedures. And we're not talking about chaos. That was back then. That was the thing. That wasn't okay either. But that now that we have a reasonable guides on how we want to work, and we want to work together, that those adaptations are real opportunities for learning. And they are opportunities for learning where we can improve too, because if someone is having to constantly adapt around something, we may think they're adapting in an unsafe way, and they may be, but that is the place that we need to invest ourselves as sort of safety professionals in understanding that. So I like that learn till I don't want to fire someone, because it helps us understand that we need to move away from, kind of the blame and culpability and those sorts of things that, by the way, we in healthcare like to think we don't blame people, but which is a whole topic. But at any rate, and that that the learning is so rich in when we're having that feeling is when we really need to double down on understanding why they did what they did. Like what was going on there.
I feel honor bound to mention that we've had Bob Edwards on the show. So listeners, if you want to go back, it was way before I had any idea of his stature in the health, or rather in the OHS community. But for our listeners, so you've mentioned that there have been positive gains, like first with standardization, but not just with that, also beyond that. What learning tools, I'm not sure if I should say, would you recommend? Because every context is different, but what kinds of learning tools have you used that you would consider successes or maybe mistakes?
Yeah. Okay. Yeah. Well, we haven't had any colossal mistakes in that realm yet. So, but I'll share with you maybe 4 or 5 things that we've used and that we're using on a collaborative level, so that, and what we're learning is that these tools are nuanced, that they can be better in different situations. So I'll just walk you through a couple of them. it's funny that I use that phrase, walk you through, because one of the ones that we have really appreciated was a walk through, talk through. We have fun calling it a WT3. And I learned about it through Marcin Nazaruk and his work. And it's the idea of standing with a person who does work and having them physically kind of walk you through what they do and also talk to you not only about what they do, but what they're thinking about while they do it. And we have found this to be an incredibly accessible tool. I just told you pretty much everything you need to know to go out right now and do a walkthrough, talk through. There might be a little bit you want to do about creating some psychological safety and, so like to set somebody up for it. But essentially that is what a person does. And not surprisingly, when we encourage people in our network to do that, what they find is that once they can establish that psychological safety with the person they're talking with, that person is delighted to share with them their experience of doing that important thing. So in areas where we find the walkthrough, talk through to be very helpful, in areas where we're either just getting started, like really just trying to learn what's going on here. Like, how does this place run? Not even sure I can define the problem here. I just know that there's some opportunity in this area. I'd like to learn more about it. Or when there's some kind of tension, this isn't maybe the one where you would want to pull together a more sophisticated, or you know that there's some issues, but you don't know if you could garner a lot of will around it. You're trying to define those better. So we have used the walkthrough, talk through a lot at the beginning of projects to help people who are especially safety professionals and leaders to really learn, the operational details that they need to in order to work on the problem. So those are, and it tends to be, you can't walk through, talk through someone's entire day, right? But like it tends to be focused more on processes. And yes, so that's a very useful tool. Another thing that we worked on really hard at the beginning of this kind of revolution that I'm referring to is we worked on our language a lot. So we appreciated that we were using language that reinforced concepts and a culture that we were actually trying to eliminate. So, things like the word deviation, things like the word investigation. And we took a lot of inspiration from Adam Johns and some of the work that he talks about. And learning always this through, not always, but often from other industries. And so there have been some really cool things written about common words used in safety and alternatives. And so we work to inspire leaders in our network, challenge them actually one summer to really flip it. Like, let's not call it an investigation anymore. Let's call it a learning exercise, or what are other opportunities? And so that was another relatively low hanging fruit, something to work on. And we continue to do that. But back to more like tool things. Another thing that we have used is something called a proactive safety huddle. And that is a sort of a semi-structured conversation with all the relevant stakeholders in a high-risk situation. And so this isn't like totally brand new in the safety world, and maybe other industries, have something like this, but it wasn't, we weren't adept at it in healthcare. We couldn't, it sort of happened kind of haphazardly or spontaneously. And often parts were missing from it. And so we brought some organization to it and taught hospitals how to do it. And in some cases, suggested places they could use it. And I think you have to be a little bit careful there because, well, I don't know. I don't know if you have to be careful right at the beginning, but I think when it grew up, the best people to identify when to use it were the frontline people, saying when to use it. But at the beginning, they're kind of like, what are you talking about? So we've had some great examples of using proactive safety huddles in patient safety and have really seen dramatic improvement in a short order. So proactive safety huddles are great. A few little, I'll just say before I move on, there are a few places where it can go wrong. And one place we see is that we came up with kind of a bare bones structure for it. Like I keep saying semi-structured because we didn't want to be too rigorous, about how to do it because different contexts, whatever. So what were sort of the basic elements that kind of pretty much need to be in place? And people struggled with that because they use this, like, we're already proactive. We already huddle. We already kind of do that. And we had to do some convincing to say, no, but you actually never have the doctor there when you do this, or you don't actually get the input from the parent. And so they don't know what's going on. And so we had to be a little bit, have these parameters, I guess you would say. And so those kind of naysayers sort of had to either come on board or not in terms of whether they were going to actually do what we call a proactive safety huddle. So that's another one though that it's not quite as ready to go right now as a walkthrough talk through, but doesn't require a lot of resources, doesn't require capital budget, doesn't require a lot of leadership buy-in. Like you can kind of do it right away, test it out and see how it goes. I think another one, the next one that is more resource intensive that I suspect a lot of your listeners are very familiar with are learning teams. And as you know, learning teams do require more coordination, more investment. They require leaders to support the participation of the people with the knowledge, and that's the frontline provider. And so that means that they're not actually taking care of a baby at that moment. They're participating in a learning team. And so it requires another level of commitment and resources than the walkthrough, talk through, or the proactive safety huddle, or the language thing that I was referring to before. But it's so powerful in terms of the ability to learn in a powerful way. And not only that, if you do a walkthrough, talk through, you show respect to one worker. One worker feels like somebody was listening to me today. And when you do a proactive safety huddle, you got a couple. When you do a learning team, you have even more. And then when you can make changes as a result of any of these, you begin to build the inferno that is this sort of this revolution that I'm talking about, so that people really begin to believe that the administration, the leadership are working in partnership with the frontline, and that the frontline are really the source of knowledge, and the rest of the people involved are working, and they're with their primary goal of making the job of the worker easier to do, safer to do, make them be able to do the job they signed up for more safely and effectively. And that's really what their responsibility is. So I think those are a couple. And the other one that we've used to a little bit lesser degree, but is also very powerful, is simulation. So when we have situations that we know are high risk, and those might be one-offs, like, hey, we're about to deliver quintuplets. We don't do this every day. Maybe we ought to walk through this a little bit. Maybe we ought to see how this is going to work. Simulation can be extremely helpful in those kinds of situations, but it doesn't have to be as one-off as that. It can be more mundane and still be very, very valuable in terms of learning. It does require resources. However, I will say that one thing that we have learned is that it doesn't have to be a high fidelity simulation. You don't have to have a simulation center and people with PhDs in simulation. I mean, I wish we could. All those things would be wonderful. And if you have them, you should be using them because they're amazing assets. But not everybody has the luxury of those. In fact, most don't. And you don't have to have them to learn from simulation. So how simulation can be another tool in proactive safety that is certainly undeniable. And we've had people, have like a watermelon for a baby, kind of thing, and they're figuring out how they're passing that and things like that. Like it doesn't have to be anything fancy. So I think that those are a couple of the tools that we are using actively in our network. And I think that there are many now examples. We have had over 100 hospitals using learning teams. So again, we've been at this now for a couple years. And so just at our recent meeting, we invited individuals from our network to tell the story of using these types of tools and evolving their culture of safety as we've just talked about and as I've tried to describe. And we had, I don't know, 40 or 50 people like share. And it's great to see it happening on an individual hospital level. What's also been super fun for me, because I'm not just a safety junkie, I'm a collaborative safety junkie. I want to see how I can get 157 hospitals. Like, what can we learn together and how do we evolve like at scale, right? Like now we're talking about even a bigger scale. And so how do we use these tools together? And that's such an interesting question because we want to be so respectful of the context, at the individual context, and yet learn at scale. And are those at odds, and where are they at odds, and where is their opportunity? So that's been kind of fun too.
Wow. Okay. Well, that's a lot of good tools and some new ones that I hadn't heard of no, I've heard of simulations, of course, but I didn't think of them in terms of this situation. But are there some resources that you would recommend to listeners if they want to learn more about anything really that you've spoken about today?
Yeah. Well, it's interesting, Mary, because I feel like your listeners are reading the same resources that I'm reading, to try to learn. So we have a website. If you want to learn more about SPS, it's solutionsforpatientsafety.org. And so we have some information and resources on there. But you prepared me to answer this question. And I have to tell you that I don't feel like I can do better than really what's on my bookshelf. We have a book club in our world, and we're reading, Amy Edmondson and Bob Edwards and Todd Conklin, and like we're reading the same things, and they're helping. And so I don't have a specific resource. I personally have never written a book. I'm not qualified for that. But I think that one of the things that I would say is whatever industry you're in, go outside of it. Go outside and learn from other people, or whatever discipline you're in. So if you're a systems engineer, read some organizational psychology. And if you're in organizational psychology, read some resilience engineering. And if you're, that, I think that, and, I think your and other podcasts can be very educational too, to kind of expose people to different perspectives. So I don't have a simple answer for that, or maybe it's a cop out, but I started to put together the list of the books I read, and then I was like, well, everybody, people, these are very well known books, and they're also excellent. They're excellent, and I'm even catching myself kind of going back and rereading some of them to kind of remind myself of the thoughtfulness that exists in the safety literature, even as it stands.
Well, it's excellent advice regardless. I always think if you want to learn about something, read about something else because your brain will naturally make the connections. If listeners want to reach out to you, where can they find you on the web?
Again, we have our Solutions for Patient Safety website, and I'm also on LinkedIn, and with an E, Lyren, Lyren, and would love to connect with anybody who's interested. I don't want to make one more comment about the books. I recently did a talk, and I like to see safety in other things. I find it very, very interesting. And I don't mean just like at the grocery store, that they have safety stuff. That's cool too. But I did this little project where I asked the people with whom I worked the closest on our team what their favorite children's books were. And then I went to the public library and children's section, which my kids are all grown up, so I hadn't been there for a while, but I checked all the books out and I read them, and it was fascinating to me how safety is in there, how this idea of the concepts that we're trying to magnify are present in these books. And so I had a lot of fun kind of taking those themes from Goodnight Moon and Goodnight Gorilla and, other No David and other fun books, the Pout Pout Fish, and translating them, which didn't take much work, kind of into the safety world. So you're kind of right. Read, right? Read and learn and talk to other people, and you'll sort of learn about safety everywhere.
Well, I hope that listeners found this discussion as interesting as I did. Thank you, Anne, for joining me today.
Oh, my pleasure. Thank you for having me.
And thanks as always to our listeners and the Safety Labs team. Bye for now. This podcast is created by Safety Products Global, the world's leading manufacturer of safety knives. Through our trusted brands, Clever, Slice, and PHC, we empower companies to prevent injuries by providing safer cutting tools for every material and application. Until next time, stay safe.